Now, in terms of some body system impairments and pathological changes that occur in patients with COPD, some hallmark things that we observe are is a metabolic inefficiency, right? So we see a fiber type shift in some muscles from type 1 to type 2. Now, whether that is due to just inactivity, patients with lung disease, for many reasons, they get short of breath very easily. So we may see some inflammatory changes, or even cell autophagy or mitophagy, which is mitochondrial mediated autophagy, occurring in these patients. So there could be a systemic reason. The ubiquitin pathways indicated as well, but so there could be inactivity, diffuse atrophy, as well as just these systemic wide changes. We see reductions in free fatty mass, or fat-free mass kind of everywhere, especially in the quadriceps, which again we think is probably due a lot to just inactivity. If you get really short of breath and it's hard for you even to breathe at rest, you're just not likely to be moving around too much. We often see a higher number or a higher resting energy expenditures, about 15 to 20% above. That's due to the increased work of breathing. And we'll talk about kind of why we see a faster ventilatory rate in these patients in a little bit, but there's a few reasons why. So not only do these patients move around a little bit, their energy expenditure is really high. We often find that patients with COPD often have difficulty eating food, and that's due to a lot of different reasons. One, just if you have if you're breathing much faster and you have challenges holding breathing at rest, holding your breath even temporarily might even be difficult. And there also may be compression on the stomach, leading to early satiety by these hyperinflated lungs. We'll go over this a little bit more later on. So again, we see these huge significant changes, in the muscle, metabolic inefficiency, change in the peripheral skeletal muscles, type 2 or just less type 1, overall just reduction in fat-free mass. And this is just because they're almost in a catabolic state. Their resting energy expenditure is just way higher. And we think this could be, probably due to some inflammatory changes that we see, elevated inflammation in patients with COPD. Specifically regarding the diaphragm, so patients with COPD generate much less force, producing capabilities in the diaphragm. We see a change at the cellular level and the molecular level. We see a fiber type switch to type 1 actually in the diaphragm. This is to accommodate for the increased frequency of loading. These patients are breathing at a much faster rate, so that endurance demands are much higher in these patients because they're breathing much faster every minute than we are. So we see a fiber type switch to endurance or these oxidative fibers, and we see a reduction in force generating capacity. We also see, because of the hyperinflation of the lungs, a mechanical impairment. So as remember, the diaphragm is dome-shaped in its relaxed state, and it contracts down into a flattened state. Well, if your lungs are hyperinflated, they're going to push that diaphragm down into more of its contracted state. We know muscles typically, have a length-tension relationship. And if we move a muscle more to its contracted state, so if you have your bicep, closer to full flexion in the elbow, its ability to generate force is going to be much less than its resting position. So we think the same, or we know the same thing happens with these patients. So we affect the length tension or the diaphragm pressure length relationship. So not only are there cellular changes occurring, we just lose some of those fast chain or glycolytic fibers or force producing fibers or type 2 fibers in the diaphragm. We also see a mechanical disadvantage due to the hyperinflations of the lungs, pushing and flattening the diaphragm, moving into its contracted state, so it has just less excursion, less ability to generate force. This can be problematic because we need sometimes, to be able to recruit larger force in the diaphragm to perform certain things like coughing or yawning, which are really important for pulmonary hygiene. They lack this ability. And again, in terms of physical exam findings, these patients will again have this, again, a chronic cough, increased speed in production. They'll get short of breath really easily with, even just minimal exertion. And we talked about the paradoxical chest movement. The paradoxical chest movements. This is often due to some of those changes in the force or the compression of the diaphragm by the hyperinflated lungs. We often see as well this barrel chest, and again, that's due to changing that force coupling relationship between the lungs and the chest wall. One, we see a hyperinflation. We're holding on to more air. The airs are just hyperinflated, right? There's more air trapped in the lungs after every breath. And the lungs are more compliant. They don't have as much of a pull back in, right? We don't have as much elastin. So that forces, that shifts that balance between the outward pull of the chest wall to favoring the chest wall. So it's going to be a little bit more expanded. So there's multiple factors that tie into the barrel chesting. Again, we talked about this early satiety. A lot of that has to do with, again, if it's really hard for you to breathe, if you're hyperventilating at rest, it makes it difficult to hold your breath a little bit for that brief apneic period that you need to swallow food. The other side is, again, going back to that hyperinflation. So what's below the diaphragm? The abdominal contents. So if you have a hyperinflated lung, it's going to compress the diaphragm, compress the abdominal contents. The stomach's going to get compressed as well. They get fuller faster. These patients have a huge struggle then maintaining adequate nutrition. They're often malnourished. And again, what do we say? They have higher energy demands due to that increased work of breathing. There's also this inflammatory processes going. They're in this catabolic state, and they're not often supplying themselves with adequate nutrition. So we're working with a dietitian with these patients, supplementing them with protein shakes, stuff like that can give them enough protein and calories while being able to not make them so full so fast. So body weight changes. In fact, body weight in patients with COPD is very strongly prognostic to their survival. If they just can't hold on the body weight, they just have this lower adaptive capacity or resiliency. And then diagnostic testing, again, we're going to see an impaired FEV1 ratio. Again, normal FE1, FVC ratio is 0.8. They're going to be well below that. And the big hit to that is this reduction in FEV1. During that first second, they are not able to get out enough air. Right? They have really problems with that, getting that air out of the lungs. We see air trapping, and that's mainly due to an increased total lung capacity. So again, the lungs are hyperinflated, and that's mainly due to residual volume. And you guys remember, residual volume is that air remaining in the lungs at the end of even a forced expiration. It's just that's the gas that we can't remove. So their TLC is increased a lot by the residual volume. Flattened diaphragm, and we talked about as well, in some patients, or most patients, we are highly dependent upon CO2 as our primary driver to breathe. Quite often in patients, they have hypercapnia, so they hold on to a lot more CO2. So they actually lose their responsiveness to other chemoreceptors. The CO2 increases because it's always increased. They might actually become responsive more to oxygen concentrations. And we'll talk more about that in terms of oxygen delivery and why you don't want to just jack up the supplemental oxygen on a patient who has COPD, because they may be actually more reliant on oxygen concentration in blood than CO2. Obviously, impaired ventilation. We also might see polycythemia in these patients to accommodate for the impaired oxygen delivery due to the impaired ventilation, and then even gas exchange due to the destruction of surface area in the lungs. Now, in terms of things that we kind of deal with as PTs, so they'll have reduced functional capacity. Again, we often track this by looking at the 6-minute walk test. Or CPT, or cardiopulmonary exercise test, or any other form of that. They'll have altered responses to exercise. They'll be their ventilatory efficiency will be really poor. They'll have decreased strength. A lot of that's due to maybe disuse and some of those inflammatory changes in the muscle. Impaired balance. There'll be a higher fall risk. dyspnea, very minimal activity, reductions in gait speed, and quite often we see chronic pain and even back pain in these patients. We think in these patients it may just due to some of the chronic postural changes, impaired sleep quality, and inflammation that we see in these patients as well, which may even decrease their ability to down-regulate pain signals in these patients. So these are some of the things we often work on with patients with COPD. And we'll talk about some of this unique changes with impaired balance and back pain in patients with COPD. There actually may be a role of the respiratory muscles here, and we'll talk about that later on in the course. So looking at pulmonary function testing, again remembering our normal flow volume loop. So again, remembering the bottom part of this is inspiration, okay? And then the top part of this is expiration. All right, this is a normal graph here, normal. This is, normal. And this is COPD here, okay? On the plot, it follows this direction, so we're going, here's our arrow there, and there's our arrow here, and there's our arrow here, okay? And I'll draw it here again, inspiration, in, expire. And this is a patient with COPD. So on the y-axis is flow, so this is liters per second. Liters per second. And on the bottom, or the x-axis, is volume, right? So just liters. Liters, okay? We'll plot this out here. So in a normal individual, when we breathe in fully, and the units don't matter as much, but we'll have decreasing. This will be our 0 point, right? And this will be our volume here. So we breathe in, covering our full volume, breathing in. As we expire, right, the peak flow from that first breath is going to be its highest, and we'll move more and more volume out of the lungs, right? So starting here, increasing volume expired at a pretty fast flow rate. Now, obviously, it decreases kind of gradually until we expel all the air out, or as much air as we possibly can. That's a normal loop, right? We see, a peak as we expel more and more volume during expiration until we're, back at our residual volume. In a patient with COPD, right, so they'll have, their inspiration will be fairly normal, but what we often observe is they have a pretty rapid reduction in flow rate, right? So here's, the peak here, and if we plotted this normally, right, it would follow this sort of morphology. However, we see this scooping, right, where the flow rate reduces very rapidly. So, if we give them enough time, they still get the same amount of volume out, but in that immediate period, they have a lot of problems because that flow rate reduces because of those flimsy airways. They're not well supported. It's most, I think, notable, right, on our volume time tracing here, where our y-axis here, if we plot it, right, would be volume, liters, and this is time in seconds, right? So in a normal, healthy individual, as we breathe out, within that first second, we get close to about 80% of what we're going to get out at the end of a forced vital capacity maneuver. So this is a maneuver when someone has breathed all the way in and are breathing all the way out. It's the same maneuver here, but we're plotting that maneuver now over time, okay, versus volume over flow rate. This is volume over time. So in a normal, healthy individual, as they breathe out, they get most of that out in that first second. Most of that's expired in the first second. And then after it, they get up to about 6 seconds. 1, 2, 3, 4, 5, 6. We've pretty much gotten all the way down to residual volume. We've emptied the lungs as much as they're going to go at FVC. In a patient with COPD or obstructive defect, again, that FEV1, that first second, they're much more reduced, right? But similar to what we saw on the flow volume loop, they get the same amount of volume out, but they just takes them a lot longer because there's more airway resistance. The airways are compressed, they're flimsy. So the flow rate, right, is much more reduced and reduces much more faster. It's basically a velocity equation problem. They just don't have the speed of airflow out of the lungs. They need a little bit more time to get that air out. The problem is, they breathe at a faster rate at rest, and especially when you begin to exercise. What do we know what happens when we exercise? Ventilatory rate typically increases to meet demand. And a patient with COPD, speed is not their friend, right, with breathing, because they need more time to get air out. So what often actually happens is patients, if they begin to exercise, right, they begin to trap more and more and more and more and more and more air until the point that they have filled their lungs even more than they can, and they can't take any more breaths in. So an example of this would be, try to take a normal breath, and then hold your breath, take another breath on top of that, another breath on top of that, another breath on top. And you don't have any more room, right, to hold any more air in, to take any more air. That basically is what happened, because they have an issue getting, liters out per second, or liters out over time, or volume over time. If we decrease the time, they're going to hold on to even more volume, and there's not going to be any more room left for them to draw in any more air, and they end up, having to gasp for air. So a lot of what we often do with patients is try to find ways for them to slow their breathing down to give them a little bit more time to get that air out. That's why in that classic picture we have here from Netter, we see this guy doing this pursed lips, right? He's trying to force air out at a little bit slower rate so he can ventilate a little bit better, get a little bit more air out of his lungs to correct that velocity equation problem. And now in terms of imaging, what we often see again is the normal chest radiograph. So again, normal is our right side here, our left side, here's our right hemidiaphragm, our left hemidiaphragm. They have this almost kind of like round edge, right? They're again, it's dome shaped, and especially above the liver. A patient with a COPD, again, the lungs are hyperinflated. So not only is it a little bit clearer on here just because the lungs are bigger and filled with air, we see the diaphragm is flattened, right? Because the lungs are compressing down on the diaphragm. They're hyperinflated in this example. And then just it gives you an appreciation again, maybe what happens with the abdominal contents. Again, this is kind of where the diaphragm's sitting here. And in these patients, we see again the diaphragm has been pushed down, it's flattened, and that's compressing the abdomen as well. And we see again this barrel chesting, again this much larger thoracic volume relatively, right, because of the hyperinflation and the changes of recoil forces at FRC, again favoring now chest wall expansion because of the reduction of the inward pull of the lungs due to the reduction in elastin. Now, in terms of gas exchange, obviously, again, if you can't really ventilate, if we have inefficient ventilation to remove CO2, we tend to retain more CO2, and if we have reduction in the ability or the surface area for gas exchange, we're not going to diffuse gas super well either, right? Even oxygen. So quite often we see hypoxemia in these patients. We see CO2 retention, which downregulates the chemoreceptor response to carbon dioxide. They actually tend to become a little bit more reliant on oxygen concentration in chronic COPD. And we also see reductions in DLCO, again, which is our diffusing capacity, because we see not only reduction in the alveolar capillary interface, reduction in alveolar walls, we also see destruction to the vasculature. So not only is there less surface area of the alveoli, there are less capillaries too. So to correct this, we often correct this for alveolar volume in COPD just to make sure the values are accurate because of the changes in the alveolar volume. The DLCO is also a way that we distinguish patients with asthma from like true COPD, because in asthma, their DLCO is typically normal. So their diffusion is still fairly normal, even though they have an reversible obstructive defect. In Prognosis, we stage COPD by severity according to their FEV1 predicted. So if I observe a patient with an FEV1 FVC ratio, again, that's fixed, not responsive to a bronchodilator, especially less than 0.7, we call that COPD. Okay, and really any FEV1 ratio less than 0.7 is an obstructive defect. COPD would be it's not reversible. So FEV1 FVC ratio less than 0.7, and then staging it's again by percentage of the FEV1 predicted. Okay, and again, remember lung volumes like FEV1 are dependent on your gender or sex, gender, your age, and your height primarily. Ethnicities thrown in there as well through the NHANES database. Mild in terms of the classification. You'll see this referred to as a GOLD classification, or Global Organization for Lung Disease. Mild would be an FEV1 greater than 80%. Moderate would be between 50 to 80% of predicted. Again, this is percent predicted, right? Not raw numbers, percent predicted. Severe would be 30 to 50%, and then very severe would be less than 30% of their predicted FEV1. So again, if someone has a FEV1 FVC ratio less than 0.7, obstructive defect, then we look at the percent predicted FEV1. So how do they fall along compared to where they should be for their FEV1? And that makes sense. Like we know that the worse their lungs are, the more breakdown we see. Generally, the worse the obstructive defect, the reduction in expiratory flow rate will be, the lower the FEV1 will be. So that's kind of why we use percent predicted FEV1 to stage severity, because we know FEV1 is going to be the thing that changes the most in this condition. A composite score we often use is the Bode index, or Bode index, which factors in both the FEV1, so the lung condition, 6-minute walk distance, their BMI. We talked again about how much holding on to body weight is important. Their dyspnea at rest, so if they're dyspneic even putting on clothes, much worse situation. If they can only move 200 feet, their FEV1 severe, they're in a pretty rough situation. So the higher the score they get in the Bode index, so if they're above 7, right, their survival is less than 18%. And this indicates a lot of what we do in pulmonary rehab is to build up their functional capacity, get that 6-minute walk test distance up a little bit higher, reduce dyspnea maybe through some respiratory muscle training, and put on some muscle mass through our nutritional counseling and strength training. We can have significant improvements on their survival. Like FEV1, probably the biggest thing we can do to mitigate that is reduce whatever is the offending agent to their lungs. So in wrapping up here, we'll talk a little bit about asthma. So asthma, again, is a reversible bronchoconstriction. And actually, you know what? We'll hold on this just because I think it works a lot better to have COPD just by itself. And we'll just do a separate little video for asthma. Thank you.